I'm going to hand the mic over to Dr. Strasser to moderate the rest of the meeting.
Awesome. Okay. So I'll be moderating the panel for our medical providers. So you guys know Jolie and Dr. Hay and Dr. Ye. Introduce Iris in case you haven't met her yet. Iris is our wonderful social worker in the Division of Neurology. She's our outpatient social worker, so if you've mostly been an inpatient, you might not have met her yet, but she deals with a lot of the social work needs of our patients. Awesome. Okay, does anybody have any questions for our medical panel? And again, you can use the QR code if you don't feel comfortable saying it out loud, but.
Even though that doesn't really apply because Sydney's not pediatrics anymore, but in the scheme of we're seeing a lot of new developing treatments, does anybody have any kind of thoughts about stem cells and if they're going to be something that is going to be wildly available and if there's any indication that it's going to be reversing or good treatment?
Okay, wonderful. I'll give this one directly to Dr. Ye.
The question is about stem cell, or there are different kinds of stem cell therapies. There's actually transplant, and then there's something called mesenchymal stem cell therapy. So with regards to the different, what's represented here, one of the things that we're very lucky about with MOG-related disorders is that there's good recovery, and the therapies we use are actually pretty good. And so using a stem cell-based therapy is actually hugely traumatic and hard on the system. So at this point, we would actually not consider those to be avenues that we need to go down because of the relative effectiveness of the therapies that we have now. So one of the big things that we have talked about over the last decades is the concept of transplant in really difficult situations. And we're just very lucky that almost all of the cases of MOG and most of the autoimmune encephalitis types of cases that we deal with, we don't have to go that far. So it's a really important question, but I'm really thankful we don't have to go that far.
Awesome. Any other questions? Great. And then I apologize, I just refreshed and saw there was some extra patient questions.
I'm so sorry that I just butted in front of everybody. So going along with that, do you think that there will ever be something to help reduce or reverse some of the side effects from spinal cord damage? Because I know that I still deal with things along with my bladder and stuff like that. It's just a little bit sensitive. I get Botox in my bladder to help kind of mitigate the side effects of the urgency and stuff like that. But do you find that there's anything that's gonna come along, or you're hearing anything that's gonna help reduce or reverse the side effects of the damage of the spinal cord?
So what you're talking about is does someone else want to take that question? Just you. Yeah, and I think this is important for everybody in the room because what you're talking about is regenerative therapies, really. So there's the side effects and getting rid of the side effects, but the real question is, can we bring our nerve cells, our neurons, back to where they were, or can we do things that help to regenerate nerve cells? Am I louder now? I'm just smiling at the ghost on Sydney's sweater. And so there is actually a lot of work that is going into regenerative therapies. There are different kinds of cells within our body which are able to wake up and make new cells. And there's a lot of work. There's actually, I'm very involved in an organization called the Stem Cell Network. And one of the primary goals of that particular specialty, the work that's being done there, is learning how we can regenerate it's not just nerve cells, even though the nervous system is the most important system in the body. But how we can regenerate those cells. So we're doing a little bit of work that doesn't get at what you're asking, Sydney, which looks at the myelin, because myelin is just a little bit easier than nerve cells. But there are other people that are, there is hope. Okay. The other side of things, and we don't have a rehab person here, but things like nerve stimulation and those other kinds of things. And for people that have trouble walking, those exoskeletons and things like that. So those things, I would say, are really important to think about as real change. Okay. Not just this isn't my body and so it's not good. And the third thing is really space age, but super interesting. And that is the ability to stimulate nerve cells at where they're from, or to bypass the circuits that are broken and make things work. And while it sounds like space age, I don't know if you guys have read about any of the work that has been done in San Francisco at UCSF with the speech, with people being able to regenerate speech with a stimulatory model. It's a neurosurgery thing. But those kinds of things, space age is coming to now. So it's a long answer, but there are, multiple ways of getting in that. It's not just making new cells.
Great. Yes. Okay. So I have a patient question, and I'm going to broaden it to our social worker as well. So I have a question for you, Sydney, specifically about what it was to be like a teenager, a young adult with MOGAD, specifically things like going to parties or drinking or like fitting in with your peers. So that's our question for you. And then I'll also broaden this to Iris and Jolie and ask them if they have any advice for any of our patients who do feel like you have this rare disorder, you're not the same as your peers. Can you be in this, can you achieve the same things? Can you do the same things? So I think it's a really important question, because a lot of the times when you're our patient, you feel like, oh, I might not ever be capable of being a normal teenager or a normal adult, which obviously isn't always the case. So if you have any advice on this, and then I'll broaden this to Iris and Jolie if they have any advice as well.
Perfect. I'll turn because I'm in front of everybody. So I think I was very, very normal. I would like to say I was normal before everything happened. But after everything happened, my mother, lovely woman, kept me on a very short leash. So that was a bit of it. So I couldn't really leave the house that much. But I find, in regards to feeling normal and being normal, a big part of that is honestly just having people that you trust, with a friend group, even if that just be one person, two person, just having people that you feel like you can be yourself in front of and feel comfortable in front of. Because if you're weird, at least you're weird with two other people, at least you're not fully alone in that. And at least you have that support system and you have those people that are really close to you who you trust. And I mean, it's very important to have, I know that we really, really preach a support system and stuff like that, but it is really, really important, because at least if you have that close knit group, you're never really by yourself. You're never really standing alone. So I think that's very important, along with the feeling weird, sick in that way, as a teenager, because I definitely did feel a little bit isolated because I was constantly going to the hospital to get my blood taken, going to do all this other stuff. I didn't really want to tell people. It was embarrassing, as a teenager, being oh, I have to go do this, and then nobody really understands. So, yeah.
Can I just add one thing? She said she was on a very short leash. She still managed to sneak out of the house with her car.
Oh my God, Mom. Yeah, busted. Why did you say that? Oh my God. Yeah, like she said, yeah. Oh. I never really did drugs in high school. It was never really something that I was into. Drinking, that's a good question. That was a good question that she asked. Okay, can you stop making me seem like such a horrible person? Teenagers drink. I'm just gonna say it. Teenagers drink. We all know. We all been there. Teenagers drink. I wouldn't say that you would have to hold yourself to any certain standard. It wouldn't affect you anymore in that way. I do find that since I was on a shorter leash, I did maybe indulge a little bit, and that was probably more on me. But I wouldn't say like I felt any other type of way, like I wouldn't have to hold myself back. Like I wouldn't have one and then just like be on the floor or something. Like I was fine. It's just the same as everybody else.
Yeah, so I think with my conditions a little bit different than MOGAD. Once I was kind of, cured, I was able to kind of move on from it. I did have one thing I probably should mention was I did have a very brief relapse back at SickKids, so they brought me back there for a little while. But I guess this can kind of be answered to everyone. I was 16 years old, so I turned 16 in the hospital, and everybody kind of says, that's the high school years, you want to go out and enjoy. My mom is a very strict person. My dad is a very outgoing. My dad's very, I trust him to do what he likes. My mom is baby him. I need to hold his hand everywhere he's going. Did he go to the bathroom today? So one thing I kind of wanted to say was I was 16 years old, and a lot of the parents in here, the kids are under the age of 18. One thing I think is very important is let them have that high school experience and let them make mistakes, let them grow, and let them live their life. Obviously, be the parent, watch after them, make sure they don't do anything too stupid. But people grow by making mistakes, and I think it's important to let them make those mistakes and let them enjoy their life. I'm not saying I lost, but I was kind of MIA for about 6 months of my life. I didn't want to keep that going once I was out of the hospital, and I kind of had my own autonomy. So I think I think the drinking question doesn't really apply to me and my condition. But yeah, just kind of let your kids live their life, let them make the mistakes.
Something that we do really, I think that is something that we do really want to stress. Like a lot of our kids do have these conditions that really affects your life, but we want you to live as normal of a life as possible. And we want you to live as full of a life as possible when you can. And we know that drinking's part of that. The one thing I'll say is we know that smoking is bad for myelin in the brain. So something like MS, smoking can be quite bad. MOG, just because smoke isn't great for myelin. We don't want you smoking or drinking or anything because we're your doctors, but.
It is a time of experimentation, but do not make your life revolve around it. Okay, everything in moderation. So we don't want you to live in a shell, but you need to remember that there are new recommendations around all of those types of things, like drinking. Well, there's always been smoking. So think about it, be wise, but experiment. Take risks, because now is the time to take risks. I just had to make that public service announcement about drinking.
It's Iris.
For MOGAD, my son, when he was first diagnosed, it was a weak positive. And when he was tested again, it was negative. Is this a condition that will be a lifetime that we need to continue to test?
Yeah, it's a tough one.
Yeah, actually, that's a very, very good question, but I feel like I still want to get to the social supports question as well. Is it okay if we just continue with Iris and Julie, and then we'll come back to that? Is that all right? Okay, I just want to make sure that we're fully answering the first question.
Yeah, I think everyone made really great points in terms of how to cope, during these experiences, post all these experiences. And I think trying to find that normalcy can be really challenging. So I really want to validate that, very, very common, very normal. And something that I often, probably always tell patients and families, having a diagnosis is just one part of you. You have so many other things that create your identity. Those goals, those dreams, the likes, the dislikes, the crushes that you have, the sassiness, the spunkiness that you have, that all really encompasses who you are. So when you're trying to figure out the world again, remember those pieces. And I think Sydney made a great point in terms of having those social supports. It is hard sometimes when people around you don't understand exactly what's going on, but you have your voice to be able to express, this is my experience, this is what I'm going through, this is how you can help me. And so talking to those people that are around you that you feel comfortable with, please engage in those supports. I think we've kind of expressed and will continue to express, if you're still having trouble with those type of connections or wanting to create more community, talk to your care teams. We can figure out other ways as well, or other opportunities that you can find other peers and friends. But again, always remember, you are bigger than your diagnosis. You have way more that makes you great. And I always like to challenge the idea of being normal. No one's normal. So kind of embrace that and own that. And I think that's going to help this coping journey a little bit, make it a little bit easier.
We get that phrase in our clinic. Bigger than your diagnosis. Yeah.
There is no normal. I think we have to move to the other room soon, so I'll just quickly say one thing that we do try to do, and it's so challenging, but Iris and I have had to try to facilitate teen support groups, because we know that even if you have awesome friends and they're help to validate you, is that no one quite understands until it's someone who's gone through the same thing. So we've tried to do online things, which are challenging, but successful when people come, and we're still trying to do things. We're trying to do in-person things, because we recognize how great it is when teens can get together. And I'm going to tell you, we've done these groups, right? And they're talking about their favorite food. They're like, oh, where do you like to go for sushi? Half the time, they're not even talking about their health. They're just being normal teens. And it's great, but they enjoy it so much. And after we think, well, they didn't even talk about this, or they didn't talk about that. But they're like, that was so great. When can we come again? Can we do something else? That was really just being able to chat with other teens. So we're trying to facilitate things like that. So that would be another thing I'd say, is that if we are having something, encourage your teens. The teens never want to come, and the parents are like, you should go, come, because Iris and I are facilitating it, and we're fun to hang out with, and it's super helpful. And because people always think, oh, they're going to make me talk about my illness, they're going to make me. No, we're not. You can just sit there, and like I said, there's times where we've talked about pets, restaurants, and it's just a free space. So I encourage everyone here, or if you ever see anything coming up, come to our groups, because I think it can be really helpful.
Awesome. Okay. We will get to the MOG questions. I'll give this one to Dr. Hay, and we'll talk about the MOG antibodies specifically and how it can fluctuate like that, like the positives and negatives. Answers to this question, Dr. Hay?
Yeah, of course. Well, I'm sure Dr. Ye will have more to add. But at the same time, I think taking it a little bit away from individual cases and more thinking about our inflammatory brain diseases. You saw some of the people in the crowd today that didn't have antibodies for their diagnoses. And even on every single antibody report that we get reported to us, it says a diagnosis cannot be made on antibody tests alone. And so it's really important to understand that when we give someone a diagnosis, it's not high positive, low positive, negative that we necessarily think of. We think of the whole picture, and why, if the shoe fits, the shoe fits. If it's weakly positive and the shoe fits, the MRI, the presentation, everything else, then we can be confident in our diagnosis. And so that's probably the first part. MOG is a newly discovered disorder, and so we're still learning what the best tests are to test for that antibody. And there are flaws. Not every test is perfect. And there are some tests that people think are better, like a live cell-based assay. And we are doing research and working with groups that do use live cell-based assays to test the MOG antibodies. And that may be a different picture for someone who comes in, and they may be positive on one test and weakly positive on a different one, okay? We're limited with what we can use in a clinical setting, and we definitely use the best option we have available to us, but nothing's perfect. And then probably more to your next question and kind of what you're referencing, if it's negative now, how long do we have to worry about it? And that's a tricky question, because we don't have a lot of data to really predict who is going to have another event in MOGAD. We have a little bit of data that suggests if you're still positive at 6 months, you're at an increased risk, but that doesn't mean that you will. We have patients that are positive and don't, and we have patients that are negative, and I think rarely do the negative ones relapse, but they have. And so it's really hard to be confident in answering that question, but I think it's also speaks more to what you can do or how to cope with the risk of having a disorder that can be relapsing. And that's something that I may actually give to Iris. How patients cope with their...
Could we complete the answering that question?
No,
but because there was a very specific question. If you're weak positive, what does that mean? And so Dr. Hay alluded to it, but I just want to make sure that everyone that sort of dealt with MOG testing understands this. So there are several levels of testing, and there's the live cell-based testing, which in a appropriate lab, not every lab that does live cell-based testing actually is able to reach the standards of the, say, the Oxford lab and the Mayo lab. But with the live cell-based testing, that's considered sort of the gold standard. We don't know if 100% of people that actually are positive, that are true positives, are found there, but we have found some on rare occasions that there are false negative. So people that we think, oh, they have to fit into this diagnostic category, but it's negative, and we send it to Mayo for the live cell-based testing, and it is positive. In other situations, we have in the fixed assay, which is what we use, the testing will show a weak positive, which is what you've alluded to. We have a number of cases that have been identified as weak positive. Most of them fit into the phenotype. Okay, when I say phenotype, they look like it's their MOG. Okay, so while it is one of the challenges that we face with MOG antibody knowledge is that we defined something before we got the antibody. We put everything together. We said, spinal cord inflammation, optic nerve inflammation, brain inflammation. And then we went back and said, all of these things fit together. And look, this antibody is positive in most cases. And so this must be the explanation, right? And within that, especially in the pediatric population, with that kit that we use, which is very, very good, sometimes there's a weak positive. In almost every case where I've seen a weak positive, I'm convinced that it is real. The fact that it went away, and it goes away in most, I showed you the numbers, in most people, once it goes away, we have a very small number of people where the antibody has gone away and they've gone on to have relapses, okay? But we do have a very, very, very small number. So that it's not zero. The possibility is never, ever zero for anything, okay? Even if I say, is this dress blue? Well, I'm 99.99% sure that it's blue, but there could be another explanation, okay? And so we in medicine are not comfortable saying never, but the likelihood that once that antibody is gone, there's going to be another event is low, okay? Unless, and these are the caveats, unless you have been on medicine that suppresses your B cells such that they're no longer, and almost everyone in this room understands this. Yes, that your body is no longer producing those antibodies, that thing can go down. Okay, and it can be zero, but once you stop the rituximab, the antibody comes back up. Okay, and in those situations, we say, well, it's gone, but it's not really, really gone. But if it's your body doing its thing without rituximab on top of it, or other B-cell agent, because there are other B-cell agents, then the likelihood that the antibody will come back is very, very small, based on our experience. Okay, because I just wanted to make sure that we addressed that question, because I think that's actually a question that almost everyone that's ever been tested for MOG antibodies has in their mind.
And I just want to ask that also, so definitely B-cell therapies, but if it's in a short window, also like the plasma exchange, the IVIG, these also work on your antibodies. So if you're seeing like positive and then it goes negative after the plasma exchange, sometimes that can happen because of the plasma exchange as well. So the fact that it went negative might just be that it's responding to therapy right now for you.
Do you want me to answer the coping question now?
Coping with relapses, that would be amazing.
Yeah. So obviously that fear and that anxiety will be there, right? That's very normal. Like, I really, really want to validate that. I think that would be like that for anyone, right? So I think part of coping is validating those feelings, saying like, it is okay for me to feel scared. It's okay for me to feel angry, to feel upset. Very, very normal. Give yourself that space to feel that. That's part of the processing of this whole experience, is allowing yourself to feel these, I don't like calling them good or bad feelings, because every feeling teaches us something. But there are harder feelings to feel than others. So those feelings are very, very valid. What can help with that is, talking to a social worker, a therapist, a psychologist, being able to process the experience. I know from our lovely speakers today, they have talked about the reality of having PTSD, whether it's from a patient's point of view or from a parent, family member. It's a very, very scary, scary experience that you've all gone through. So it's important. Our physical health is just as important as our mental health. And so it's really important to take care of those pieces. Again, connecting to social supports. And a big thing I always tell families is, we can't control the past, we cannot predict the future, but we can stay present. So it's so important, stay present in this moment, because this is when you can actually do something. So whether it's, again, enjoying the time with your family and your friends, attending events like this, where you can be educated, and just having fun. You still are allowed to have fun. Right? That's part of growing up, is having fun. And like we said, making mistakes, learning from them, being silly, and getting to know your identity. So part of that, though, is being present and allowing yourself to do that. So there's some things for coping that you can do.
We have time for one or two more questions. One virtual question. Oh, it says 2:55. And it's a break after, so if you have any questions and want to stay, you're welcome to, but, okay. One question you guys can go at any point if you don't want to stay, don't worry, we're not holding you captive, but if you want to stay, you can ask more questions. We have one question about oxygen therapy, and the use of oxygen therapy within neuroinflammatory diseases. I assume so, yes, but oh, okay. Yeah.
Sorry. I've heard about this just recently. Somebody suggested that when I was talking about my son's condition, say, hey, ask about oxygen therapy, whether they said it's been used for slowing aging, for treating certain Alzheimer or mental problems. And I just thought to ask if, and I'm not sure what kind of oxygen therapy it is, to be honest with you, but I just thought to ask the question.
I feel like it's probably hyperbaric based on how you're describing it, but good question.
Okay, hot potato question goes to me. Yeah. No, so hyperbaric oxygen therapy has been around for a very long time. And the way that it's the mainstay of hyperbaric oxygen therapy is related to burns. Okay, when you have let's say you've had a house fire and you get third-degree burns, one of the ways of helping recovery occur relates to hyperbaric oxygen. And I believe for carbon monoxide, they put people in hyperbaric oxygen. So it's there are different uses. For many years within neurology, there has been debate, and I will use the word debate, over how useful hyperbaric oxygen can be. And for even 20 years ago, there was talk about hyperbaric oxygen for something called cerebral palsy, which is a permanent and irreversible injury to the brain that results in stiffness and weakness and it affects children. And there were a number of trials that suggested that there was no benefit to hyperbaric oxygen. There are other people, it comes up periodically. The question about hyperbaric oxygen comes up periodically for a number of different disorders. Right now, there is no evidence that it can help remyelination or regeneration, neuroregeneration. The main challenge that we face with things that are not proven, and I'm the first to say that what we're doing, and I'm being very honest with you guys, I've talked to every single one of you in the room to say what we're doing is something that makes pathobiologic sense, but there's no big trial for it, but we are giving you this medicine. So we are in that space of doing things that are challenging to the outside world to say, is this working or not? However, what we do know mechanistically is that the things that we are doing have had effect, and in parallel situations, they have effect. And we've been able to witness, as we observe, that they make a difference. The challenge with something like hyperbaric oxygen is that it's the mechanism doesn't make the biology doesn't fit well with, and the kinds of changes that it might bring about are usually thought of in sort of a chronic stage where hope might be generated when people are feeling hopeless. And what we want to avoid is to have people spend a lot of their personal income or money or savings on things that aren't proven for hope that we don't have any proof for. At least within our profession in medicine, we're not charging to try things. And so I get very uncomfortable when there's a profit motive that might be behind some of these therapies because they're not OHIP covered, They involve travel to different places. They involve danger, they involve risk. So I don't want to be a naysayer, I don't want to be negative, but I want to try as best as I can to encourage you to not be taken by the hope when there are other things that money might be better spent on. I hope, I don't want to be too negative, but I certainly support people trying many different things. It's just when it gets to be spending a lot of money going different places, it makes me uncomfortable.
So a few things I just wanted to add to Dr. Ye's point. There was this, I don't know if you guys remember hearing about it, but in the MS field, which I know is a little bit separate from this, there was this liberation treatment where if you just got your veins dilated, it would help treat your MS. And this one research paper was done, and it was a huge, there's a lot of excitement about it in the MS community to the point where people were going to Mexico and getting this procedure done. And really, there was no evidence at all. My mom has MS, and she was like, I'm going to Mexico tomorrow. I'm going to go get this procedure. And in reality, there was no evidence. Like, there was one paper, and it really she didn't go get the procedure, but it was proven not to be very effective. And so it's really important that it's easy for us to take a step back and be like, hey, look, we're just looking at years and years of literature, and we're putting it all together into this kind of understanding. But it's really important to be a little bit mindful of these experiments, or not experiments, treatments that may not be truly fully flushed out. And then as a second point, I think for all of you going forward, whenever you interact with healthcare professionals, I think a true sign of a good, healthcare professional is being able to answer these questions. I've heard it not just about hyperbaric oxygen, but about bee pollen. I'm sure you've heard about a lot of different things. It's really important that we can provide you the actual information that's out there. So never feel bad about asking, even if you think it's weird or different, your healthcare providers about what might be helpful.
Don't be afraid that we're going to judge you. I think this is really important. Don't be afraid we're going to judge you. You got to show us what you, it's sort of like being a parent and having a teenager saying, you know, if you're doing drugs, I want to know. Okay? It's the same kind of thing. We're not going to judge you if you want to try something, but just tell us so that we're sure that what you're doing doesn't interact with the kinds of things we're trying to help you with, and also that what you're doing is something that's not going to be harmful. We'll always talk to you, we'll always listen, and we will not judge. We will only try to help.
Awesome. Okay, I think that's a good point to end it on. Okay, we have one last question. Okay.
Acupuncture, right? Something that you don't.
Well, acupuncture has a long history. I would not put acupuncture in that.
Yeah, I mean, acupuncture is very interesting, yeah, with the microphone, but they've done studies. Some people respond to acupuncture well and some people don't. And as with a lot of other things, if it works for you, it works for you. But acupuncture can do some really powerful things in the published literature. I think it's just not fully understood. And there's a lot of experience with acupuncture and a lot of publications on it. Just be mindful what it is and how you react to it if you're going to use it. And if you have an open wound, don't get acupuncture.
And it's OHIP supported.
Yeah.
That's, I mean, people aren't out there like, you know, and there's licensing, there's oversight, it's a very
This one will be really quick. I know when I was diagnosed with NMDA 10 years ago, there was even less knowledge about it now and what causes it. I'm just curious if you, either Dr. Hay or anybody up there, can tell me if you guys are leaning more towards a reason for it to come up. Either it's the flu, it's your body's reaction to the flu, or if it's anything else that you guys are starting to see a trend with now.
This is going to be a group answer because I think one of the reasons why you're asking is because we've had an influx of patients, and we've actually asked you to come and chat with them on the floor. And certainly there's a lot. I've geeked out with Dr. Ye and Dr. Strasser about what could it be? Is there something in the water? That type of question. I don't think there is, but more broadly speaking, what can cause it? We know that in kids, the reasons that NMDA receptor encephalitis occurs is not necessarily always the same reason that occurs in adults. I mean, certainly it could be, but like the teratomas we were talking about. Certainly there's a thought that it could be post-infectious, and there's a thought that it could be teratomas that aren't yet grown that we can't visualize yet that we would recommend screening for as you age. But I think the jury's still out on all the possible reasons it could be, except for Dr. Ye probably isn't.
I would say that that NMDA is a post-infectious phenomenon in children, except in the 6% or so, in whom teratomas are seen. And if it doesn't come back, there's no teratoma there. What I was alluding to earlier, and I've been thinking about over the last little bit, and more so over the last week because of some results we have on some of the experimental things we're doing with an immunologist in Toronto, is how much does that primary infection, that primary hit that you get from an infection, a specific infection, lead to some sort of hyperimmune response? And is this why we see it so much more in kids than in the adult population, the post-infectious version? This is true of MOG. We've published information how in the pandemic we almost saw no MOG, pretty much no MOG. And then when the pandemic stopped, we saw a ton of MOG, and we saw a ton of everything actually. And so my thinking is that it is a post-infectious phenomenon, but it's an interaction between the environment and what you're made of and the cells and where they are in that particular developmental stage. That's my, like, it's not written in a textbook, but that's my thought.
right. Thank you, everyone. I think we're probably going to have to end if that's okay, just because we only have 5 minutes until our next session. We already are into the break time. But I just wanted to stress, we really appreciate you guys asking questions. Like they were saying before, we know you're asking these questions because you really care about your loved ones or because you're the ones who are living with this. So you're the ones who are the most up to date in terms of you're looking into things, you're seeing what happened for other things. So we're always very happy to answer your questions. And please, like, never feel shy to reach out to us or to ask us at the appointments. I wanted to say thank you so much to our wonderful panel, to Jolie, to Dr. Hay, to Dr. Ye, and to Iris. And again, to Chris and Sydney and Pam, we can always tell you, like, oh, NMDA, MOG, like, this is what we expect. But I think actually seeing patients who have come out the other side is a totally different story. So we really appreciate having you here. And thank you so much, everyone.